Hi there, I'm Dr. Gerald Berke. I'm the director of the UCLA Voice Center for Medicine and the Arts. And I'm going to speak to you today about management of the professional voice. I have some slides to show you, and at the same time, if you have any questions, hopefully you can get in touch with us and I'll be happy to answer anything that comes about. So the first thing that we're going to talk about are some measures that we use to measure voice and some of the difficulties that we have in using these measures. Basically, they involve imaging, acoustic, and we'll talk about that, aerodynamic, and perceptual measures. So we're going to start with acoustic measures. There's a plethora of acoustic measures. The most famous ones are some complicated measures called jitter and shimmer and signal-to-noise ratio. I'm talking to you about this just to really point out that many years ago we used to kind of do 40 different acoustic measures on every patient that came in. And the reality is that many of them are not very useful, and we really don't do that anymore. But you can certainly find centers that continue to measure this and try and use that as a means of describing voice. And we're only bringing it up to really say that they're not really all that measurable in certain patients, and we'll discuss why in a few minutes. Aerodynamics, measuring the airflow through the voice that creates voice, is another measure that people use. And in the past, we used to believe that these linear flow measurements were very important in understanding voice, but you can see that in discussing them, and you can see that the airflow actually comes out of the vocal folds almost like a tornado. It's not really very linear, and so our previous way of thinking about this has certainly changed quite a bit. Perceptual, that is to say, the way our ears listen to voices, is probably the gold standard. Again, that brings up the issue of perception is largely subjective. The way that you hear something and the way that I hear something is really quite different, and it's very hard to quantify that. But nevertheless, we use perceptual measures as a means of kind of deciding whether somebody's voice is pathologic or getting better or very nice. I wish I could give you a whole bunch of different ways of saying, oh, this patient's voice is going to be hoarse and this voice is going to be much better, but I really can't do that. So we're going to fall back to that in just a minute. So how do we hear voices? I think we're just kind of getting off to the start here. And really, we hear voices as an integration of a number of subtle factors that combine to produce the impression of an individual's unique vocal quality. It's a gestalt, a unified whole. It's not really easily deconstructed into its components. So when this multidimensional, this multifactorial perceptual concept is applied to a singing voice, it can become even more difficult to classify a singer's voice due to the myriad of factors that are encountered. For example, did Janis Joplin have a good singing voice or a poor singing voice? I would venture to say that it was a great voice, but it really characterized her quality of singing. And so we can't really say that this particular voice is good and this particular voice is bad. Perhaps the best we can do is to try and obtain a feel for a particular performer's expressiveness and their vocal artistry and try to understand why they believe it's impaired and utilize our training and experience to return them to a functional level of performance. While at times you can kind of perceive a fundamental theme, that is to say, hoarse, strained, let me go back here for a second. Hoarse, strained, muffled, strangled. There's a number of elements, though, that kind of group together to kind of define that. And as I alluded to, we really can't separate those elements very well. We hear it as kind of a central whole that affects us. Unfortunately, laryngologists demonstrate poor concordance in trying to separate out these elements, and we're not really going to do that today. We're just going to discuss kind of this overall global theme. Maybe to make matters even worse, patients don't really always hear what their voice sounds like. I have a lot of patients that come in that say, I can tell that my voice is better, but I'm not really sure if it's better or not. Now, I've listened to voices for many, many years, maybe over 40 years, and I can hear very subtle changes in a patient's voice and can discuss that with them, but it's very difficult at times to break that down into the certain elements that contribute to make someone's voice better or worse. So there's some important non-medical questions that we use to discuss with a performer or a professional voice user that really helps us decide whether or not I can help them and how to classify what's really going on with them. And I want to mention some of those right now. So what's the style of singing? Are you a rock performer, pop performer, legit opera singer? How much training have you had? Who are your vocal coaches? Those are really all very important factors in deciding how we treat patients. What's the range that you had? How is your mix? How is your transition from modal voice to falsetto voice? How is that occurring? What's your warm-up schedule? How long do you warm up for? What's your current performing schedule? Are you about ready to go on a huge tour? Are you coming back from a large tour? Do you have other factors, people at home or in your environment, that's contributing to some of these issues? What are your current venues? What are some of your past venues? What's going to happen in the future? Who have you seen for your voice, and who do you continue to see for your voice? Where do you live? Are you near UCLA where you can come visit us at our voice center? Do you live in another totally different environment? Is it going to be difficult for us to get in touch with you or see you in the future? Tell me a little bit about your lifestyle. What are some of the how do you treat yourself? Do you go out drinking after a performance? Are you very good about taking care of your voice? Do you understand a lot of the factors that are necessary to maintain a good voice quality? Tell me a little bit about how you've been feeling. What's your emotional state? What are some of the stressors in your life that are now contributing to your performance? And how might we help you deal with some of those? And then finally, can you demonstrate the issue that you've come to see us about? Are you just here for a check before you go on a big tour? Is there something that's really significantly happened to make your voice different? And can you show me how that is? And we'll talk a little bit more about how we can help you look at that and actually record your voice. You know, performers, when they're not doing very well, don't particularly like to go into a recording studio and record their voice, but it can be really useful to have them do that in a professional setting so that they can hear how they sound like from day to day or after a particular treatment or that's been suggested to them. So, now that I've spent a little bit of time kind of confusing the issue and reminding you that it's very hard for us to measure voices precisely, one thing is for sure. Great entertainers have an uncanny ability to alter our emotion and lives by performing their artistry. And so the remainder of our discussion today will help us focus on how we as caregivers can help you maintain those special qualities. So, in many respects, our voice is a little bit like a violin. There's a sound source, namely the strings that vibrate. There's a sound resonator, which is kind of the plate on a violin. And then there's a sound radiator, these F-holes that radiate the sound that our voices produce. So, in a similar way of looking at it, the sound source really is our vocal folds. They vibrate and they make noise. And then that sound is passed through our vocal tract, which is really our airway, which is the sound radiator. And then our lips and our mouth actually radiate that sound out to you. And we'll look at that in a little bit more detail here. So about at the level of our Adam's apple, or about right here in the throat, is really the sound radiator. And these are our vocal folds. And really our vocal folds, or also called vocal cords, actually vibrate when we pass air through them. And I'll show you that in a minute. But they're really constructed of a mucous membrane. There's a kind of a dense structure called the ligament, and then underneath this mucous membrane, which is a little bit like a kind of like a jello type of very soft vibrating material, is a number of muscles that actually can tighten or loosen. And believe it or not, we have extrinsic muscles. Those are muscles in the neck. And then we actually have muscles themselves within the vocal folds that can be tightened or loosened. And we have a tremendous amount of control over all of these muscles to help us control our voice and change the way that we use our voice and produce sound. So these are the vocal cords. They attach right in the front and they come in to the back here as well. So I'd like to show you a video. This is a high-speed video of the way that the vocal folds vibrate, so you can get some idea of just how fluid and different they are. Now the vocal folds actually vibrate beyond the fusion frequency of our eye. That is to say, they vibrate so fast that our eye is unable to actually see an individual vibration. But when we use a stroboscope or a high-speed camera, we can actually slow that down to the level where we're able to perceive them. And let's see if I can do that. I don't know, maybe you can start that going. There you go. So this is a high-speed filming of the vocal folds, and you can see, I'm going to put this down for a second, that they're actually kind of doing this. And every time they do that, they actually interrupt the airstream that's going through them, and that interruption of the airstream is actually causing a pressure wave to actually flow throughout our vocal tract. You can see it's a pretty interesting thing to see, and when many patients see that in the voice laboratory and the clinic, they go, wow, that's the most dynamic thing I think I've ever seen in my life. So this looks like a complicated slide, but I'm going to try to describe it in a fairly simplified manner. So the vocal folds vibrate, as we discussed, and as they're vibrating, air pulses are coming out of them. And the air pulses are coming out at a particular frequency that we hear in our voice as a fundamental frequency. But it so happens that the discontinuity in the way that the vocal cords vibrate does not produce just one frequency, but it produces a whole spectrum of frequencies. We call those spectrum of frequencies a complex sound. So the vocal fold makes a complex sound. It's kind of almost like a buzz if you hear it. But that sound then passes through the vocal tract, and some of these, we call them harmonics, are amplified and other harmonics are diminished by the shape of the vocal tract. And then it comes through the lips and the sound is radiated. It so happens that our ear has this unbelievable capability of determining the amplitude of the different harmonics and interpreting that as the vowels and consonants of language or speech. So for instance, when I go from O to E, O-E. Our ear can hear that very rapid change in the amplitude of the harmonics and interpret that I'm going from the vowel E to the vowel O. Now, the interesting thing is it's pretty similar to the way when we hear a flute play a note and we hear a piano play a note, our ear has this ability to go, oh, that's a flute and that's a piano, even though it's playing the same note. And the reason that it does that is because the amplitude of the harmonics are different. And really, just in about the last minute or two, I've given you basically the way that the acoustic theory of speech production produces speech. Next slide. Oops, I have the slides. So, another interesting concept that I'm not going to spend a lot of time on, but I'd like to mention is that singers have this unique ability to shape their vocal tract to try and improve the quality of the sound that they're making. And they do that in a variety of ways. There are some structures above the vocal cords, the false vocal cords. We also call it the vestibule, that they're able to scrunch down, and that adds an additional kick to the push that's coming out from the air puffs of the sound, and that changes the quality of the sound that's produced significantly. So take somebody like Ethel Merman. She had this unbelievable, unique ability to change the shape of the structures above her vocal tract so that she could really belt. And when she was singing like Everything's Coming Up Roses and just belting out the tune, she was able to change the shape of her vocal cords to allow her to really belt in that quality fashion. Or take somebody like Dame Joan Sutherland. She recognized that certain vowels don't have the ability to provide this pushback, this extra kick to the vocal sound, and she could actually change the vowels of some of the words that she was saying in order to change the quality of the sound that she was producing and allowing her to hit those wonderful notes that she was able to produce. This is just a slide kind of demonstrating that the resonator, the vocal tract, is able to change its shape in order to produce even better sound than it would have by changing the structures that it produces. So getting on to maybe something that's a little bit more in medical, or abnormal vocal cord states. A lot of what we see in patients that come to see us is inflammation of the vocal cords. This can be due to reflux laryngitis, very common problem in singers, maybe in fact the most common thing that we see, patients that just have stomach acid that comes up and burns their vocal cords without them recognizing that this is what's happening often. About 40% of patients don't have the classic heartburn symptoms that you would expect. Allergies, and then of course voice abuse. Teachers are very, very prone to this. It's common amongst that profession. Then there are mass lesions, and we'll look at that in just a minute. Nodules, polyps, cysts can occur on the vocal cords from abuse or sometimes just for unknown reasons. There are neurogenic causes. They can either be in the brain or peripherally that can lead to problems with the voices, and that includes a paralysis of the vocal cords where patients are unable to control the fine muscles of the vocal cords to produce the quality of the sound. A weakness, we call that a paresis. Dystonia. Dystonia is a spasm of the muscles, and believe it or not only can the muscles be weak, but they can be too strong and they can be in spasm. And patients that have that have a very particular type of strangled voice, and it becomes very difficult for them to lead on normal life activities. And then, of course, there are a number of neurologic illnesses, Parkinson's disease, Shy-Dragger. You can go down the list. Multiple sclerosis, where patients have changes in their voices because they have these chronic neurologic disorders. Of course, there are functional causes as well. Stress, tension, conversion, malingering, all can lead to changes in the way that somebody uses their voice. And a laryngologist, somebody that deals with these patients, has to be very skilled at trying to determine what's actually going on here and why has this person come to see me with this unusual voice change. And then finally, malignant and pre-malignant lesions occur on the vocal cords, and they have the ability to change the actual vibration of the vocal cords and cause the voice to change significantly. So I hope you can kind of see this. These are different pictures of lesions that we commonly see on the vocal cords. Right here you can see there's this little kind of reddish nodule. This is a hemorrhagic nodule that occurs. Believe it or not, although most patients would go to a doctor and say, we got to take off this nodule, I've learned a number of years ago that if you just say, do you need to sing, it can go away on its own. And a lot of lesions that occur on the vocal cords, if we can just put the voice to rest, let them rest, it will just clear up by themselves, and surgery really isn't necessary. Some patients can actually develop, it's called a granuloma, but it really is proud flesh. Imagine if you had a sore and you came by and you scraped it all the time here. Eventually you'd build up this little tissue right here, and you can see that right here on their vocal cords. Also, they usually go to a doctor and the doctor says, oh my God, you have something on your vocal cord, we need to take it off. But all they do is they re-injure the area and the lesion comes back again. Sometimes after they've had 2 or 3 repeated insults, the doctor will say, well, go see Dr. Berke, and then I'll say, oh, well, we just need to treat this with some Botox to rest the vocal cord and it goes away. So it's important that a patient that has a lesion on their vocal cord get a couple opinions about it. And having said that, any patient that's been hoarse for more than 2 weeks without it really getting any better should have somebody take a look at their vocal cords. Some other lesions, here's a big cyst that's occurred on the vocal cord. Cysts usually, believe it or not, need to be excised. You can see the redness right here. This is really indicative of a hemorrhage, a hemorrhage into the vocal cord, and when that happens, the blood collects and it prevents the vocal cord from vibrating, producing that nice wave and the voice changes. Those patients require rest, and usually to take care of whatever was the inciting cause, whether they were yelling, whether they were abusing their voice in any fashion. Some patients that smoke, and smoke a lot, the heat from the cigarettes can actually cause the vocal cords to become quite edematous. And we call this Ranke's edema. And they have, you can imagine, instead of the nice trim shape to the vocal cord, it's really floppy and their voices are really bad. And those patients, before I take care of them, have to promise me that they're going to stop smoking, because if they continue, the lesion's going to come back again. And then finally, in the corner over here, you'll see this white lesion on the vocal cord, and the vocal cord looks kind of like something's been eating it. That patient has a cancer of their vocal cord. And we typically see white lesions on the vocal fold, which can be malignant or pre-malignant. Sometimes they're just a buildup of tissue, and of course they need treatment as well. So common problems in singers. Reflux laryngitis is a really common problem, and oftentimes a singer who's really not that well trained will come in not realizing that this is their instrument, this is their way to communicate their artistry to the public. They need to treat that, and it can be treated with antacids, diet, and sometimes rest. A lot of singers we see have performance anxiety. You know, it's not that hard to get up in front of a lot of people and perform your artistry. Doctors, in many ways, not only are counselors, but they have to understand the stresses that their patients are under and try and help them cope with a lot of that as well. Poor vocal technique. Fortunately, in the vocal clinic, we have vocal coaches, we have speech pathologists that can help patients oftentimes recover from a lot of these technique problems that they have, and we have a number of people outside and within UCLA that we can refer them to. As I implied, dreaded hemorrhage is a big problem, and patients need to have counseling for that and treatment for it. And then I showed you some of the mass lesions that occur on the cords as well. So just in summary then, I'd kind of like to reiterate that the vocal cord vibration is a specialized form of vibration. It's not too dissimilar from the vibration that occurs in collapsible tubes. You know, when you blow up a balloon and you let it go and it kind of flitters around the room and makes a noise. That's kind of the way the vocal cords work, although obviously it's a very highly specialized organ. It's a multi-layered structure, and anytime you go to a doctor or a laryngologist, they have to understand the structure of the vocal cord and the way that affects how the vibration occurs. We have central control over all the extrinsic and intrinsic muscles of the vocal cords, and that allows us to change the way that our voice operates. So when I go, which is kind of a silly thing to do, but I'm controlling from my brain all the extrinsic and intrinsic muscles to change the shape and change the sound that's emanating from my vocal tract. The extrinsic muscles change the stiffness, the tension, and the geometry. The geometry and the stiffness alters the frequency and contour of the vocal fold, and that alters the characteristics of the airflow pulse, which eventually produces the quality of the sound that's produced in both healthy and diseased states. And as we alluded to, the vocal tract then changes that sound to produce speech, singing, and language. Vocal folds are very robust. You know, we don't really appreciate just how robust those structures are, but when they're injured, they can affect our lives greatly and pretty much just change the way that we carry on our daily activities and even have really negative psychological consequences to patients that experience them. Proper vocal hygiene is essential to professional voice users and includes a proper diet and rest. And then finally, I wanted to give you a couple brief photos from our beautiful voice center, which has much donated art. It's a really beautiful place to be. It's in the B of A building, and it's a very private facility with a special entrance. And believe it or not, we actually have our own recording studio within the Voice Center that allows professional voice users to hear their voice when they're in good shape and when they're having issues with it, so that they can tell what they need to help work on to improve their professionalism. UCLA Health was very gracious in allowing me to give you this brief talk. I hope you enjoyed it. If you have any questions, please don't hesitate to contact us. Thank you very much.
Good.